Thank you so much for inviting us to present this video. I'm Jessica Ardila. I'm one of the PGY3 general surgery residents at the Cleveland Clinic. Peroral pyloromyotomy is one of the endoscopic and surgical treatments to gastroparesis refractory to medical therapy. This is a 34-year-old female who had a history of idiopathic gastroparesis, requiring both a feeding jejunostomy and a venting gastrostomy tube. In 2012, she underwent a gastric emptying study that showed delay, for which she underwent a placement of a gastric electrical stimulator. This had only transient effect. She later underwent pyloric Botox injection, which also had transient effect. She comes to our clinic and a laparoscopic pyloraplasty versus an endoscopic pyloromyotomy were offered, and she chose endoscopic approach. It is in our practice that if we have a patient with gastroparesis that are not diabetic, not morbidly obese or malnourished, we offer a laparoscopic pyloroplasty or an endoscopic pyloromyotomy or POP. The procedure, it's similar to the poem, consists of creating a submucosal tunnel just proximal to the pylorus, extending all the way distal to the muscle, then proceeding with a pyloromyotomy and finishing with closing the mucosotomy with endoscopic clips. So the surgery starts with injection of the submucosal plane with methylene blue and epinephrine solution to raise the mucosa from the submucosal plane. We do this just proximal to the pylorus along the lesser curvature. Then we create a mucosotomy using a TT knife and electrocautery, a transverse mucosotomy. Using the tip of the knife and the endoscopic dissecting cap, we deflect the mucosa downwards to get access to the intramural space. Now we proceed to create the submucosal tunnel using electrocautery and constant insufflation of CO2. So we create the tunnel along the muscle just distal to the end of the pylorus. Then we proceed with the pyloromyotomy. We use electrocautery to transect the muscle layer by layer, and we like using starting distal to proximal. In our institution, we have performed just above 50 of these cases in the past year, having good results and good patient satisfaction. So to identify when we're transected the entire muscle, we transect all the white fibers, and then we see the serosa posteriorly with a thin blue stain from the injection of the methylene blue. Once the pyloromyotomy is completed, then we proceed with closing the mucosotomy with multiple endoscopic clips. The surgery was just under 30 minutes, and it was without any complications. The patient remained with nothing by mouth, and on postoperative day number 1, she underwent an upper GI that showed no leak or obstruction, and diet was advanced as tolerated. Thank you very much.